Good morning. I'm Dr. Steve Stites, Chief Medical Officer at the University of Kansas Health System. We're coming to you live from the Dolph Simons Jr. Family Broadcast Studio. Thank you for joining us here on Facebook, YouTube, and Twitter. Today on Open Mics, we're going to explain why a presentation on metastatic breast cancer received a standing ovation at this year's American Society of Clinical Oncology. Spoiler alert, there may have been a few tears of joy at this year's annual meeting. We invite you to get your breast cancer questions into us now on YouTube, Facebook, and the Medical News Network. Those links are on your screen. The American Society of Clinical Oncology wrapped up their annual meeting earlier this month. It once again provided a roadmap of scientific advances for the treatment of cancer. Our guests today, including, because I am surrounded by them, three professors: Dr. Roy Jensen, Vice Chancellor and Director of the University of Kansas Cancer Center, good friend of mine. Roy and I go back for a lot of years. Dr. Priyanka Sharma, who was a chief resident with me. That's a long time ago, too. Professor and also the Assistant Director of Clinical Research and Co-Program Leader for Drug Discovery, Delivery, and Experimental Therapeutics. Priyanka, we're going to shorten that because that is really a long title. And Dr. Jennifer Klepp, Professor and Director of Cancer Survivorship and the Co-Program Leader for Cancer Prevention and Control. Dr. Klepp's clinical practice focuses on cancer genetics and survivorship, a term we really like, survivorship. Dr. Jensen, before we get to our big news, help our viewers understand this annual conference. Who goes? What happens? Why is it so important?
Well, ASCO, or the American Society for Clinical Oncology.
Much easier to say. We're going to call it ASCO here on out. I like that.
Is essentially the biggest cancer meeting in the world. And it's held every year, usually sometime between 50 and 60,000 people attend in Chicago. It's always in Chicago.
That's a lot.
Because it's one of the few convention centers that can hold a meeting that is that big. And it is, I think maybe celebration is not quite the right word, but it is to some extent a celebration of everything that everyone across the world is doing to move the science of cancer clinical care forward. And there are almost always significant breakthroughs that are announced at this meeting, and it's always exciting.
So that is a pretty big deal. You know, I go to the CF meetings, and for a long time there weren't many CF breakthroughs. We're at a 10th your size. But we used to say it's 50% science and 50% pep rally. And back in the days we didn't have a lot of drugs. The pep rally was more important because you had to keep everybody excited, keep them in the game, because we knew that good things were coming down the road. And Dr. Sharma, the presentation that received an emotional response was around a breakthrough with HER2-low breast cancer. You're going to have to explain what all that means. How do we say it right? Why did it get a standing ovation? What's going on here? What's HER2-low?
So the presentation that received the standing ovation was called the DESTINY-Breast04 study that looked at a new drug called trastuzumab deruxtecan. I'm going to shorten it to TDXD.
I was going to say that again. I want to hear you say that 3 times in rapid succession, or at least 1 time so I can hear you. What was it?
Trastuzumab deruxtecan, or TDXD. We all refer to it as
TD. I like that, but that's a TDXD.
It is a newer class of agents called antibody drug conjugate, and I'm going to shorten it to ADC, which is how we refer it to, or often we refer it to as smart chemotherapy. And the reason we call it smart chemotherapy because it has a chemotherapy that's attached to another molecule, and that molecule attaches to the cancer cell directly and allows the chemotherapy to be delivered directly inside the cancer cell, hence smart chemotherapy. So what the DESTINY-Breast04 study showed that this smart chemotherapy, TDXD, when compared to conventional chemotherapy, led to higher tumor response rate, higher duration of response, and most importantly, the patients who got this compared to conventional chemotherapy lived longer.
So how much longer? How much response are we talking? Like a day, a week, a year? What are we talking here?
So more than 2/3 of the patients had a response with this drug, and it improved, on an average, it improved overall survival by 6+ months. And these are averages, so we know many patients will do much better than that, and many won't get to that point. But in breast cancer, so I think that a couple of reasons why this study got standing ovation and tears of joy. And I can tell you, I've been going to ASCO for 20 years now, and this is the only second time that I've seen a study receive a standing ovation in a plenary session. The last time it happened was almost 20 years ago, when first line of HER2 therapy got presented. And again, that changed the landscape of how we treat that cancer. So the reason this study, I think, got standing ovation was two things. Number one, for a new drug to show that patients will live longer with this medicine compared to our conventional agents in breast cancer is a rare occurrence, and this study showed that. And number two, I think it opens the door for a new class of drugs to be available for a large proportion of patients with breast cancer today, but probably other cancers down the line, and which brings us to what HER2 low is. HER2 is present, it's a protein that's present in almost 65-70% of all breast cancers. But up till now, for conventional HER2 drugs to work, we needed a high level of HER2 expression for these drugs to work, and only 15-20% of breast cancers had this high level. What this new drug and this study shows us that another 50% of patients with breast cancer that have low level of HER2 expression, now we have a very effective agent that is available. And I think this is just the beginning of that era. We will have other agents that will get added to the list, and clearly better treatment options for our patients.
Well, I like that sound. And so, Dr. Klepp, how is this going to change? How is this research going to change how patients are treated and how they do, and this whole survivorship? Hopefully, it's going to make your survivorship clinic a lot busier.
Well, survivorship is something we want and we offer to all of our patients, but in particular, I think for these new subpopulations of breast cancer, it's really giving, like Dr. Sharma said, additional lines of therapy, but they're very well tolerated. And so I think that's always a question for our patients, is to balance out that quality and quantity of life. And so this gives them an option which improves survival. It has a very manageable sort of side effect profile. And as we heard, we're getting into these new subsets of patients where we'll continue to have more options for them.
So that is pretty exciting. And so when we say the HER2 low or HER2 low and now triple negative, what's that about? What's triple negative breast cancer?
Well, you have one of the best experts in the world on triple
Sharma.
Negative breast cancer is Dr. Sharma. Yes.
What is triple negative breast cancer?
So triple negative is kind of a wastebasket term in breast cancer. About 80% or more of breast cancers will express one of the three markers: estrogen, progesterone, or HER2. So cancers that don't have any one of those three get put into this lump category of triple negative breast cancer. And by default, because it doesn't have all of these three markers, it has lacked targeted therapy and effective treatment options. It is also, just because it has the three things absent doesn't make it the same. So it is also very heterogeneous or different within itself. But we're making progress for triple negative breast cancer. There are newer drugs that are now showing promise, that are improving survival response rates, like immunotherapy and also antibody drug conjugates. About 30% of, quote, triple negative breast cancer will have this HER2 low protein. So I think the trastuzumab deruxtecan or TDXD is another option for these patients that we will have available in clinic. But we at EU do a lot of research work on this particular subtype of breast cancer.
Okay, so one of the three of you have to tell us in lay terms, what does antibody conjugate mean, and how does that drug work?
So lay terms. So antibody drug conjugate. So antibody is a molecule that attaches to the cancer cell. It by itself is not very effective cancer therapy. And the drug is a chemotherapy that's attached to that antibody. So that antibody attaches to the cancer cell directly and delivers the chemotherapy inside the cancer cell, as opposed to our conventional chemotherapy, where we give the drug intravenously or people take it orally, and it gets into your entire body and is supposed to find the cancer cells. Here, the antibody part of it finds the cancer cell because it attaches to specific protein that is present only on the cancer cells and allows.
Exciting.
Yes.
So that would be very targeted then, as opposed to just kind of this general assault on every cell, which is why people get so sick with chemotherapy, right? This is much more targeted. I'm betting it's better tolerated by patients.
It is. It is in general better tolerated for sure. And there are different types of antibody drug conjugates. And as I said before, we sometimes refer to these as smart chemotherapies. So they can get to the cancer directly instead of causing many side effects on the body. So this is really a major advance in cancer therapy in the last 3 or 4 years. And we will see many generations of better ADCs, even better than what we have today, come along in the next few years.
You know, this is a really big deal. What an amazing time. We've talked before about CAR T therapy, Roy, and now this. I mean, help us frame what the impact of this is on cancer, because, I mean, this is something you've been fighting for your entire life.
Well, exactly, and I think Priyanka's done a good job of explaining why this is such a big deal. You know, we've gone about as far as we can possibly go with cytotoxic chemotherapy as a general agent. And it works really well, but unfortunately it has many side effects because it also attacks normal cells. And this is kind of the next generation of where we think chemotherapy is going to be, you know, 5-10 years from now, where we take an antibody, which of course is something made by the immune system to specifically attack something, and then hook that up with a cytotoxic chemotherapy drug and greatly increase the specificity of the attack. And so this is, I think this is going to be the dawn of an era where, you know, maybe, you know, 10, 15 years from now, we don't give just a cytotoxic chemotherapy. It's always
targeted therapy.
It's always targeted. Yeah.
That is such a big deal, and you've got to feel good about this. With it, I bet the patients are excited.
Patients are excited because it's going away from one-size-fits-all care, and it's very specific based on information from what you heard, those 3 markers of estrogen, progesterone, and HER2, to other types of genetic markers. And so everyone is getting a treatment that's based on their kind of genetic footprint versus getting that kind of kitchen sink approach. So it's very exciting.
And we know it makes such a difference when you get into the genetic footprint a little bit. In my world, CF, you know, we've done huge strides because we have drugs that are very specific to defects, and we have to know the defect. We give you the right drug, and you can have a miraculous outcome. So it's, God, this is an exciting time to be in medicine, right? It's an exciting time to be in medicine. All right, well, still ahead, more from the ASCO conference on breast cancer, including the impact from obesity and genetics. We're going to go now to some questions already. We're going to head to Studio B on Jessica Lavelle. Jess, do I have to confess to the audience that this big spot on my head is where you slugged me? Is that what that is?
I tried to cover it with some makeup, but it didn't work.
You did. Actually, it is so important. Everybody go get screened. I had mine in dermatology yesterday, and you know, when you go to a dermatologist and you're a white guy who's had a few sunburns along the way at age 60 plus, okay, maybe 60 plus, you get whittled. And so I got a little whittled yesterday, but all is well. All is good.
I'm glad you're getting your screening. That makes me happy.
All right.
Okay, question from... Okay, I've got a question from Sarah. What are the odds of surviving triple-negative breast cancer?
So the odds of surviving triple-negative breast cancer in this era is 80+%. So even though we call it the hardest to treat subtype among breast cancer, most patients still survive this cancer with the current therapies that we have available. Of course, we would like to move that needle up from 80 to 90 to 95%, and hence investigation of newer ways to treat this cancer with lesser side effects are continuing on.
So Erica wants to know, and we get these questions a lot, about how to stay healthy and avoid having to come to see you all, our specialists. So is there any advice on just lifestyle, diet? If you maybe had to talk about some top things that you could suggest that people do to avoid getting breast cancer or any cancer at all.
We have our expert on lifestyle here, Dr. Clem. So
I think Dr. Stites brought up a great point. We need to get screening. So whether that's colon cancer screening with colonoscopies or other types of tests, mammograms and other types of breast imaging, skin screening. We have lots of tools in our toolbox that are still underutilized. So we need to be able to take those tools and make sure that everyone is aware that we all have risk for cancer. It doesn't matter who we are. Some of us have more risk than others, and we need to make sure we're using the screening tools. And then the second piece with lifestyle is sort of the hardest thing that we have, but it's the thing we can control. We can't control a lot of things in our lives, but we can control if we are able to move and do some exercise, kind of if we can try to achieve a healthy weight. And those are so hard for so many of our patients. And I know we'll dive a little deeper into that, but I think screening and sort of diet and exercise are two tools that we need to sharpen and make sure that everyone is using them to the best of their ability.
Yeah,
the other thing I would add to that is there are a number of vaccinations
absolutely.
that you can have that will decrease your cancer risk. For instance, the hepatitis vaccine essentially eliminates hepatitis B as a cause of liver cancer. And so HPV, of course, has been in the news a lot, and Australia is well on its way to eliminating cervical cancer, and it's because there's been a tremendous uptake of the HPV vaccination in that population. And
so
so
are you saying
we
that
have
vaccination
that
works?
Absolutely.
What do you know about that? I think it works for COVID too. What do you know? Shocker.
It is.
Well, I
Vaccines
think
works.
that if you ever go onto the CDC's website and look at the decrease in cervical cancer, you can't believe something happened so powerful in such a short period of time. So I think that is the best evidence in a single picture. Yep.
Jess?
Last question for the moment, but Jennifer wants to know, can breast cancer come back after getting a double mastectomy? And if so, where might it show up?
Dr. Sharma?
So yes, breast cancer can come back after getting a double mastectomy. In fact, when breast cancer comes back, it often does not come in the breast. So having a double mastectomy often doesn't provide any level of protection greater than having surgery on just one side where you had the cancer. And the most common sites that the breast cancer recurs or comes back in are bones, lungs, and liver. We commonly see patients in follow-up every 3 to 4 months and are asking questions about symptoms related to these organs, checking blood tests to assess for any signs of recurrence. So I usually tell my patients that if you have any new signs or symptoms, aches or pains, a cough or a belly pain that persists for more than 2 weeks and isn't tied to anything else that you can relate to, then please let us know. Come back to clinic and be evaluated.
That makes such a big deal to make sure you stay in good follow-up. Jess, I think you had one more question.
I do. I want to ask Isaac's question, and it's a good one. Are there any characteristics that are common to all cancers, like a protein or a gene marker of some sort that could be targeted by future therapies? Like, what would they all have in common?
Dr. Jensen.
Well, that is a great question, and unfortunately, the answer is no. Cancers have certain behavioral characteristics, but cancer is literally thousands of different diseases, and we have learned that through genomic sequencing and tumor sequencing of DNA, where almost every single cancer that's diagnosed is unique to that individual. Now, they have common characteristics that we can utilize to select treatment, but cancer is a really tough opponent in terms of it is always changing shape and doing trying to survive and adapt to whatever therapy we throw up against it.
It's always trying to go about it and just trying to. It's almost like SARS-CoV-2, man. It keeps mutating back in a different way. It's hard like that. All right. Well, let's get back to a moment here. We're going to check for a moment with Medical Director of Infection Prevention Control, Dr. Dana Hawkinson. Hawkeye.
Hi.
What's going on today, man?
Hey, it's looking pretty good out there. As far as cases in the United States, although right now here in the health system our hospitalizations are going up. 19 active infections, 1 in the ICU though. and that person is on the ventilator, but 10 in that recovery period. So, Steve, our cases have gone up a little bit for active infections in the hospital, but I think we're really seeing this plateau or this dip in cases nationally. Overall, I still think it is a good omen right now as far as we aren't seeing that huge surge that we did previously with Delta and Omicron.
I think that's right. You know, if you look at the numbers around the community, whether it's wastewater testing or what the percent positivity rate or what we project the actual numbers of cases to be, we're probably having more disease transmission than we did during the Delta surge, which had lots of hospitalization and lots of death.
Yeah.
Yet the death rate has stayed the lowest it's been during the entire pandemic in the midst of the surge. That's got to be some form of good news about immunization and immunity.
Yeah, absolutely. You know, again, there are absolutely no restrictions out there in place to help mitigate any spread of the disease. Yes, hopefully people are doing things outside. We've always been a proponent of that. But otherwise, you know, being indoors, there are no mask restrictions, no capacity restrictions. And just like what we are seeing, what we saw in South Africa, what we're seeing in the UK is even though they did have a lot of cases, they weren't seeing that large amount of hospitalization. And that probably does owe to that individual immunity, again, through vaccination, but also those people that have been vaccinated and infected, and otherwise those people who had been repeatedly infected as well.
You know, I think the other key message to this is that it's circulating so rapidly and shifting so rapidly, we still have to be a little concerned, right? Because in the last few months, we've gone from Delta to Omicron to BA2.12 to BA2 to BA2.12.1 and now to BA4.5, which we project to be the dominant strains. So we're constantly circulating new strains while we're out there, yet the death rate has fallen. To me, it's this funny thing. You like for COVID to just go away, but if it's not going to go away, if it circulates and we maintain an immunity and people keep getting vaccinated, hopefully the death rate is going to stay low unless a new strain comes out that's more immunogenic.
Yeah, you know, I think that's right. I think what we had seen before were those other variants. They were quite different from each other if we're talking about alpha, delta, beta. And now we have this new variant, Omicron, and it seems like the last 2 or 3 other subvariants are from that the Omicron variant of concern lineage. So hopefully right now we can stay with that. We know that the vaccine companies are working on vaccines really directed against the original Omicron variant. So we'll just kind of see what happens. Overall, we know that we continue to have that very good immunity to protect against hospitalization because of our T cell immunity. Those T cells really recognize things that aren't changing that much on spike, and so I think that is helpful, and that is I think that is really one of the main components of that immunity that helps protect from hospitalization.
Yeah, we continue to build the airplane while we fly it, but we're a little better pilots than we once were back at the beginning of this, Hawk.
Yeah.
You know, there's some evidence out there that COVID may be causing a hepatitis outbreak among children in 34 different countries. What do you think?
Yeah, you know, if this is the pediatric hepatitis cases, actually CDC just published a study in MMWR looking at that, and what they found was that they did not find an increase in the true rate of those children who have hepatitis or need liver transplant from prior to the pandemic. So maybe our recognition of that is much better and it's come to light more. But what they saw was that the baseline from pre-pandemic till now did not change. So I think we're still doing investigations, but I think that report that came out, I think a week ago, was pretty insightful.
Hawk, I don't have a child 6 months to 5. And I don't think you do anymore either, but if you did, would you get them vaccinated?
Yeah, I'm all for vaccination for sure. I was so happy to get my children. They were really at the age, I think when the age got reduced for the HPV vaccine for my son, I got them vaccinated as soon as possible on their yearly exams for vaccines.
It's a big deal. All right, let's get back to our guests. We've heard about the initial exciting clinical trials in regard to breast cancer. That's a pretty big deal. Dr. Klepp, there is news related to ductal carcinoma in situ, or DCIS, another way of getting things shortened down a little bit, that suggests a new standard of testing for patients with this early stage of breast cancer. Explain that to us.
Well, I think that so many patients ask about personal history and family history in regards to genetic testing, but we still have barriers to patients getting tested. And this study just happened to focus on the non-invasive type of breast cancer. So I kind of like to think about the breast as sort of a tree, and these are the trunks and the branches of the tree. And so it hasn't left sort of its home base. And the important part of that is it's very curable. I mean, almost 100%. But you want to make sure that you understand the true risk for that patient in regards to their genetic risk. And when we talk about genetic risk, this is what you inherit from your mom or your dad, not what Dr. Jensen just talked about, kind of the tumor sort of changing. This is actually what you were born with. And if we know that sort of genetic footprint, then we're able to say that you have a higher risk of a new primary cancer, not just breast cancer, but other types. And so we may adjust not only your surgical management, but if you had an invasive cancer, the type of chemotherapy or treatment, and then also how we screen you going forward. And then probably most important, which all of our patients ask about, is sort of their legacy. Well, what about my daughters, my sisters, and my sons? So I think that this study highlighted that we still have a poor uptake. It was only about 35% of patients with a new diagnosis of ductal carcinoma in situ that were in this population actually sought out to get genetic testing or were recommended to get genetic testing. Overall in breast, we're doing the best, but it's still probably only 50 to 60% of patients who are eligible are getting tested. It's even worse for colorectal, prostate, pancreatic, you name it. So we need to really be thinking about, for every patient sitting in front of us, do they qualify for testing, which most patients now, especially with certain types of cancers, it's 100% that they qualify. Ovarian cancer, certain types of breast cancer, young patients. So this shouldn't be a barrier. This should be something where it's part of our algorithm. We see a patient sitting in front of us, we recommend that, and so many of our patients are also asking about it. But I think the impact for management and for being able to really address that long-term risk is vital for these patients, because I always hate to see a patient who had a lumpectomy with radiation, 2 years later they get genetic testing, now we know they have a mutation, and they're going back to then do more aggressive surgery, but they're limited by the types of reconstruction because it's already been irradiated breast. So these are just sort of the quality of life issues that go along with that.
It is so complicated, not what it wants. All right, so let's talk a little bit about diet, exercise, and the risk of breast cancer, teams. Some more information came about that too with ASCO.
There's always updates on lifestyle, and to sort of frame it for breast cancer, we know that postmenopausal women it's an associated risk to be overweight or obese for developing breast cancer. And then regardless if you're pre or postmenopausal, it is a risk factor for reoccurrence and overall survival. So weight is a big part of how we should be managing every single patient that walks in our door. But as we all know, any of us who've struggled and had challenges with losing weight, this is really hard.
It is hard.
And it's something.
As you get older, it gets harder.
It gets harder. And we can't just give you the magic pill and boom, it's gone. So every patient needs like a recipe. And the nice part is the recipe is really the same for cardiovascular disease prevention, diabetes prevention. Yeah. We want to be a healthy weight. We want to stay active. We want to do some weight bearing and some cardiovascular sort of exercise. But I think the hardest part is how do we get that into sort of your day-to-day and reset so that patients understand that this is really part of their treatment as well, is focusing on lifestyle. What happens every year is that we see lots of studies, and studies help patients lose weight through drastic diets, or there's studies going on in metformin with breast cancer. We can help patients lose weight. We've done lots of studies where we help patients lose 10 to 12% of their body weight, but 3 years later, 85% of them have gained or more.
Back to them.
That's right. So I think that this is an important part that we all need to be thinking about. And what I always tell patients too, and myself, is let's say you're on your own program of excellence and you have a bad day. Tomorrow's a new day. You have to keep pushing that reset button. And I think people, once they kind of get off their program, they feel like, oh, I've already messed up. I just can't get back on. But you can. So you need to keep hitting that reset button.
I'm impressed. So, when I was a younger man, say 40, I weighed about 155, 160 pounds. I could eat anything, and I did. And, I never put on a pound, right? I struggled to put on weight. Now I'm 62, and I can't eat any half as what I used to, and I put on weight. And it's funny, I got up to 190 one day. I was like, how did I get to 190? What happens as we get older, guys? What's going on here? Because we can't eat as much.
Right. So lots of things happen, but a lot of it's related to our hormones, both men and women. And when
Wait a minute. Are you saying men have hormones?
I'm saying men do have hormones, and we go
Yeah, my wife
through
thinks so,
menopause,
too.
menopause. Everyone goes through some sort
You
of
have
pause.
hormones.
Hopefully.
We all go through these transitions, and for a lot of our patients in breast cancer, hormonal variation starts in their early 30s, and they don't kind of realize that, but that's when these changes start to happen. And what happens, with lowering estrogen, it affects our metabolism. You see this sort of soft belly weight that occurs, and that belly weight is called sarcopenic weight gain, and unfortunately, that's the bad kind of weight gain. So for breast cancer, as you heard from Dr. Sharma, breast cancer often likes estrogen in a majority of breast cancers. And even when our ovaries are no longer producing that estrogen, fat
We're just going to do it.
Fat will produce it because we still need it for our bones, our heart, our brains. And so it's going to make it, and we're going to use it. So that's another reason why it's important to kind of keep that weight down. But it's hard.
It is hard, but we got to work at it. You
We
gotta
do.
change your diet, exercise more. It's a hard recipe. Eat less, exercise more, and that is the recipe. And eat healthy, of course.
It is.
So.
And I think the last piece, once again, I like to talk about tools in the toolbox. We don't utilize medical management for weight loss like we should. So I know that, we have an amazing program at KU for weight management, but we need to be using all those tools because lifestyle is always the framework, but there's other things that, especially if people are having difficulties, don't hesitate to ask and maybe get access to experts who can help with medical weight
We
management.
need to do that, Jess. Upcoming program, we're going to focus on weight loss because there are some really great scientific developments around that. Dr. Sharma, you are principal investigator for the SWOG, Southwestern Oncology Group. I love all the abbreviations we use today. We're trying to make it confusing. The SWOG Cancer Research Network and co-principal investigator for the Cancer Center and Masonic Cancer Alliance. Holy cow, those are a lot of words. Tell us what it is you're researching.
So our primary research focuses on triple-negative breast cancer and really diving deep into the biology of the disease so we can understand which tumors respond to what kinds of therapies. Fortunately, now we have so many different options to choose from, and you can't really subject an individual patient to all of those options. It's just too toxic and not realistic. So looking at the biology to determine which patients will respond to chemotherapy A versus B, which patients will respond to immunotherapy versus not, the new antibody drug conjugates will really help us personalize the treatment and optimize the treatment where the right treatment gets to the right patient with lower side effects. The other thing that we're really working on is to study chemotherapy regimen backbone for curative setting that is devoid of long-term toxicities. For long duration, we've been using a class of drugs called anthracyclines, which are very effective for breast cancer, but do increase risk for cardiac toxicity down the line and increase risk for bone marrow cancers like leukemia. So we would like to get away from these drugs, at least in the patients who don't need it. So that's another thing that we've really focused on, to develop a chemotherapy regimen that does not have this anthracycline class. And we cure patients from their breast cancers, but we want to do so without increasing the risk of other cancers down the line.
Okay, so that's a pretty big deal, and good luck on that research because that would be absolutely awesome to do that. So, it's Dr. Jensen, this has got to feel good to watch these other brilliant people around you work and do things and research in cancer and know that an NCI designated cancer center, this is what you do.
Absolutely. I mean, cancer centers were really built to do exactly what you just said, is bring people together from many different disciplines, whether they're clinicians, basic scientists, population health researchers, and all come together to make a difference against this disease. And, frankly, that's the reason why pretty much every single major advance against cancer has taken place or been accelerated by the work taking place at our network of NCI designated cancer centers across the nation. And it's played a huge role in decreasing the mortality rate. Since 1991, cancer mortality has dropped by over 30%.
Holy cow.
And, I don't think there's another disease out there that's had that kind of success.
Maybe HIV.
HIV.
Some of the infectious diseases.
Yes.
That's about it.
Yeah. So, but we know we still have a long way to go.
Yes.
And the demographics are frankly against us. By 2030, the expectation is that we will increase the number of cancer cases by nearly 50%. And that's because by that time, almost a quarter of the American population will be 65 years of age or older. And that's obviously prime time for getting cancer. And so our incidence keeps going up, but our mortality is going down.
So Jess, let's see, are there questions from our community or reporter questions today?
I do have some community questions and quite a few for Dr. Hawkinson. Marianne wants to know, first of all, she's wondering, when was the last death from COVID that happened in the hospital? Do we know that?
Oh gosh, I don't know.
Or approximately?
Before I left for vacation, I think it was really that end part of May, but I don't know since that time.
It's been a while, knock on wood,
that
and that's, again, reflecting, we just have fewer patients in the ICU, a lot fewer patients in the ICU than we've had.
Yeah.
I mean, the ratio of having, 20 patients or whatever and 29 altogether and only 1 or 2 in the ICU, that's really good.
Patty wants to know, are the vaccination boosters changing to cover the new variants?
Well, they haven't changed yet, Hawkeye. There's a lot of information coming on from Moderna and Pfizer, and they've gone to the FDA with some data to see they may want to pivot the vaccinations a little bit, but that's not official.
Yeah, I mean, you're exactly right. Right now, it's the original formulation, again, that original Wuhan isolate, or the WA1, as it's been called at some point too, that spike protein. That still has done very well. Obviously, we have seen, as Dr. Stites had talked about, some more antibody evasion with new BA4, BA5, but it still protects very well. But they are working on, say, a bivalent vaccine. So 2 different spikes, the original one, and there is a component of the Omicron spike as well. That data is being collected now and analyzed. I think a lot of people do anticipate maybe producing or rolling out one of those vaccines with the 2 different spikes in it in the near future, possibly this fall. So, but all that data is being collected right now.
Susan has a question that we've been getting a lot as far as when to time out getting that second booster. She said she's heard that more than likely there's going to be another injection booster available in the fall, wondering if she should get her number 2 booster now or just wait until September, October.
Okay, I've been telling people in my clinic, it comes up a lot actually, that if you have things that especially put you at risk and you haven't had COVID, you probably ought to go and get a booster right now. If it's been more than 4 months, go get your booster. And yes, you may get another shot next fall, and that's okay. If you're completely healthy, or if you've already had a booster and you've had COVID, that may put you in a different category. You may be able to wait a little longer. But especially patients who are older, people who have cancer, people who have autoimmune disease, people who are transplants, you need to stay up to date on the boosters as soon as possible.
Yeah, we've seen that these vaccines are safe. People have gotten a lot of doses. There's been no problems with that. So the safety is there. If you had COVID, I would wait at least those 2 months. Certainly, CDC would recommend saying that 3-month range. But anytime after that 2 months, I think it's okay to go ahead and get that second booster. If you are due for it now, I would just say get that second booster now.
Okay, Jean wants to know, and I'm not going to pronounce this correctly, I'm warning you. What do you know about the nitric oxide nasal spray, Lagavrio, for treating COVID?
Yeah, nitric oxide nasal spray, a little early.
This isn't the vaccine?
That's not the vaccine. I think some people have tried using nitric oxide as a therapy. We've used nitric oxide in other disease states. We used to use it in sepsis and infections and in ARD, adult lung injury, etc. And there are some, in critically ill patients, sometimes NO may have an effect, especially in pulmonary hypertension. But in general, NO I don't think it's a big therapy for it.
Yeah, I would certainly be in favor of investigating that and doing the clinical trials properly. The bar is set fairly high right now, though, for therapies, as we have Paxlovid, the outpatient therapy, also remdesivir, which can be used inpatient, outpatient. We know there's monoclonal antibodies, but we know that there are treatment modalities that we need to continue to look at for those people that are critically ill in the hospital as well. And so certainly all for the investigation, but I would kind of echo what you said, Dr.
Yeah, and I think there are investigations undergoing for both inhaled as well as intranasal vaccination techniques, but we're several years away from that still is what I'm seeing. So. Jess.
Last question, Dr. Stites from Isaac. I remember reading a while ago about efforts to create a universal coronavirus vaccine. Do you know anything about that? Any updates?
I don't think that's been advanced beyond. I think there's been so much focus, Hawkeye, on SARS-CoV-2 that the other coronavirus types have not been actually, and I'm not sure we need to. I mean, to be honest with you, standard coronavirus it's not a big deal. I mean, we're going to be okay with that.
You know, they are looking at it just like you said. We know they've also been looking for a universal influenza vaccine so that you don't have to change it every year. Because we know in the current influenza vaccines, there are 4 strains that are included in those. And so even if we did have a coronavirus SARS-CoV-2 vaccine with 2 different types of spike, again, that is not unheard of. We have a precedent with the influenza vaccine. But overall, we know that they are looking at it. It's just probably going to take a little bit more time, and are the resources directed towards that? But those are questions, those are investigations that are ongoing as well.
We need to make sure we get the world vaccinated. All right, Jess, any other questions right now?
That's it from in here.
All right, we have had an amazing discussion today, and I am I just can't tell you what a joy it is to be around these 3 terrific folks from the cancer program. You know why we're an NCI designated cancer center when you hear these guys talk about cancer, because they have such great thoughts around it, and they're also actively engaged in research. Dr. Klemp, final thoughts from you.
I think the exciting part about cancer research today is that we do have lots of trials looking at some of the things that you've heard about today. But I think that besides that, anytime a person's diagnosed with cancer, they become a survivor. And whether they're living with or through their disease, it's really important that we make sure that we're thinking about them comprehensively, that we're making sure that we're managing, like you heard, late effects like cardiotoxicity or bone health. And so the important part of you, the patient, is that you're part of that process, and we need to engage the patient to be a really active member of their team. And by doing that, that means we're going to, kind of have a seat at the table. And I think that's really important for survivors to sort of fill their role and let us support them while they are an active part of their care.
Yeah, it's a big deal. And Dr. Sharma, I'm going to come to you for your final thoughts. But as part of that, just remind us, men can get breast cancer too, so everybody needs to do that self-exam.
Yes, men can get breast cancer too, and especially the men that have a genetic mutation in certain genes like BRCA2 are predisposed to breast cancer. So certainly if there's a lump or an abnormality that is felt, it should be investigated promptly for men.
Right. Thank you. Okay, final thoughts, since I just pirated yours.
Final thoughts, I think we're in the exciting time in cancer treatment. Our understanding of the biology of cancer has evolved so much in the last decade that is leading to newer, more effective, personalized drugs. And that's what I'm the most excited about, that over the next decade, I anticipate that our approach to treating breast cancer is going to get so much more individualized as opposed to kind of the shotgun approach that we had a couple of decades ago.
Yeah, what a big deal that is. Man, the idea of directed therapy is revolutionizing medicine. Dr. Jensen, final thoughts.
Yeah, there's no question about that. And, this is the year that we're renewing our cancer center designation. And we could literally hear at any moment back from the NCI on the results of our site visit, which we had in February.
Yeah, what's in your email right now, by the way?
Yeah, I need to check my phone. And we're looking forward to that because we've gotten great feedback, and I would say we're in a really good place. Yeah,
this is a great time, and to say you've done a great job being our director. Hawk, final thoughts.
Yeah, I think it's so incredible and amazing working with this group of physicians and the Cancer Center. Do it every day. They have put forth their blood, sweat, and tears to help the people of this community, and we've seen it here. And I think it's just new and exciting things that we continue to see that come out from the research there. So.
I think it is an amazing time to be in medicine, and I'm always impressed. I would always just say to my CF patients, you got to do all the preventive therapies. You got to stay alive really long because new therapy are coming around the corner. I would say that's the same message from y'all today, right? If you take the preventive measures you can stay alive because such new therapies are coming down the road, and you can do the things that set you up for success. Hope does spring internal, and when you've been in medicine long enough, what's really cool is when research delivers hope that wasn't there the day before. And that is an amazing time, and that's what gets a standing ovation. Thanks for being with us today. Don't forget, you can catch our shows anytime by logging onto Facebook, YouTube, and Twitter. Tomorrow, we look back on the pandemic 2 years ago. The airplane didn't fly so well then. In our special encore episode of the Morning Medical Update, focusing on how our local media handled COVID-19. We'll be back live Friday at 8 a.m. Make it a great day, and remember, hope means everything. Live long and prosper.
Children acting out. For many parents, they would say this is nothing new. I'm Jessica Lovell. Friday on the Morning Medical Update. What's the reason behind it? Plus, why Kansas City could be going more green. We'll see you at 8 on these social media channels.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.